Hello and welcome to this talk on how to cost the implementation of major system change. My name is Clarke and I work at UCL in London. These are my lovely co-authors on the bottom of the slide here from various academic and health service institutions in London and in Manchester. I'm very grateful to be able to present this talk, even though it's online instead of in person due to the things that are going on at the moment, and I will dive straight in. So I'll start off with a bit of background. Major system change in this context involves reorganisation or reconfiguration of healthcare services. The idea is to improve patient outcomes and reduce running costs, possibly through economies of scale. There have been a number of studies published on the impact of major system change on quality of care and on patient outcomes, but very few have looked at the cost effectiveness of major system change, and even fewer have considered the cost of implementing the change, despite there being potentially large costs involved. So why are these costs ignored? Well, they're often considered to be sunk costs, although this ignores the fact that work done looking at the cost of implementing one major system change could be useful when planning a different change. Economic evaluations of major system change are a type of service evaluation, which is a complex thing to look at. There's a lack of randomisation. There are also unhelpful assumptions around cost effectiveness, where it's assumed that if running costs are reduced, then the change overall must be cost effective. But this isn't a given, and there's a lack of data to check whether or not this is true. So the aim of this paper is to try and convince people not to ignore implementation costs. We've produced a framework based on ideas developed during previous work on the reorganisation of acute stroke services. And we describe this framework and illustrate its use via a case study. The case study is the Respect 21 Mixed Methods Evaluation, which is looking at the reorganisation of specialist cancer surgery services in London and in Greater Manchester. Delays in the timeline, unfortunately, have meant that we can only focus on the London changes in the health economics part of the analysis. So now I'll tell you a bit about the case study that we're using to illustrate our framework. Since 2009 or thereabouts, London Cancer, as it was then called, has been working towards centralising specialist surgery services for some cancers. The cancers we're looking at here are prostate, bladder, renal and OG cancer. The Respect 21 study is a unique data collection opportunity, as the study itself is taking place alongside the planning and implementation of the changes, rather than being a retrospective study. It's a mixed method study, so there's a number of complementary aims. Firstly, we're qualitatively evaluating the processes of MSC, so how it's been done, who's led it, who's been involved, and the impact that it's had on people working in the services, and some of this work's been published already. Secondly, our statisticians are looking at the impact on patient outcomes, so mortality and other outcomes, using a difference in differences approach. And the health economics aspect builds on these two strands and focuses on the cost and the cost effectiveness of the changes. So this is the framework that we've developed. The first question to ask, as with any economic analysis, is who is my analysis for? Or what is the decision that this analysis is trying to inform? Cost effectiveness analysis is a decision-making tool, so thinking about the decision maker will tell us what costs and other information we need to include. In the case of Respect 21, we're using B, the local or regional perspective, specifically looking from the perspective of the group of service providers in this region. The 5 components in the framework are arranged here broadly in chronological order. So firstly, the different options available for the new service configuration would be looked at. Sites that want to become the new specialist surgery centre, for example, would submit bids, and these are reviewed. There would be an engagement process for communicating and engaging with patients and the public, and with those who work in the service, to make sure that everyone's views are heard. Various planning boards and meetings would also take place over the course of planning and implementing the change. Then the change itself would happen, possibly involving buying new kit or hiring staff. These are the other things that form part of the framework that we'd need to know about for cost analysis, on top of the 5 components from the previous slide. There are various things in here. I won't go through them all in detail in the interest of time, but I will highlight that the lifetime of the changes that you can see at the bottom is particularly difficult to estimate. So this parameter will need some sensitivity analysis to explore the impact of making different assumptions here. It relates to how much time we think passes between subsequent service reconfigurations, which is quite a subjective thing in some ways, as there are reconfigurations going on in the NHS at different levels almost constantly, depending on how you look at it. A bit more about the methods for our case study. So we've done bottom-up costing as opposed to top-down costing. This means that we identify different items and applied unit costs, and the total implementation cost is the sum of all of this. We've identified key reconfiguration stages and expenditures, and again, this is a collaboration between all the different members of the study team. There have been many data sources. hundreds of meeting minutes gathered by the qualitative team, hundreds of records of qualitative interviews, as well as conversations with the NHS managers and clinicians within the study team to help build a picture of where time or money might have been spent during the implementation. We also obtained business cases and other detailed information on costs from finance managers at sites and other clinicians, managers and consultants who were involved at the time. And we've included costs from the 28th of February 2012, which was the first relevant board meeting of the London Cancer Board, up till the 1st of April 2016, which is the date by which the changes had been implemented in London across the sites involved for all 4 cancers. So the results of our cost analysis are that the total cost over this approximately 4-year period was £5.1 million over a catchment area of 3.2 million people in that corner of London. The 5 components that we had from the framework helped us to identify costs and helped in our discussions with people that we were collecting the information from. We discovered that people's time actually ended up being spread across components and we couldn't really separate that out. So we had 2 ways of looking at that. There's time spent in board meetings and there's time spent by key actors, who are specific named people who spent a proportion of their time on the 4 cancer reconfigurations. This total includes the costs for 2 replacement robots replacing old existing ones. So there's 1 robot at the prostate and bladder site and 1 robot at the renal specialist site. Part of the reason for these being replaced was related to the sites being specialist surgery centres. We've also included costs for shared activities across simultaneous reconfigurations. So there were actually 8 cancers that were being reconfigured across this part of London, and cardiac services were also being reconfigured at the same time. So we've included the 4 that we have, that's prostate, bladder, renal and OG, because they were the ones that London Cancer had in common with Greater Manchester Cancer. You could argue that the costs for these shared events and activities would be the same, regardless of how many services were discussed, because of fixed setup and planning costs involved with events and meetings. Or you could argue that fewer healthcare staff would be involved if we're looking at fewer pathways. Both of these viewpoints are valid, so we've varied these things in sensitivity analysis. So to look at the results of the sensitivity analyses that I've just mentioned, if we excluded the costs for robots, then the total is reduced by over half. So it comes down to 2.3 million in total if we take out the robot costs. And there are various reasons why you might want to do that. You can see pictures of these robots on the right-hand side of the slide here, so you can see that they are quite involved and expensive bits of equipment. If we change the way that we looked at shared activities across the 8 cancers and cardiac changes, so these are some of the engagement and consultancy work that was done. If we instead try and split it up, then we would reduce the total slightly, down to 4.4 million if we attribute half of these costs to our 4 cancers and half to the cardiac reconfigurations. And the total reduces a little bit further if you then also split the cancers in half. We can also look at using different time horizons. So for a slightly shorter horizon, we get a slightly higher total, as you'd expect. And for a longer time horizon, we get a lower total. And these are the figures here, including the robot costs. But you can imagine that they decrease correspondingly if you take out the robot costs. So there are various limitations in this case study. The main glaring one is that there's no counterfactual. So this is a one-armed cost analysis. What this means is that we take the results at face value. They're implying that without the reconfiguration, there are no costs of other possible innovations or changes that could have happened if we hadn't done this particular reconfiguration. But this is unlikely to be true. Equally, though, there's not a lot we can do about it, as it would be difficult to estimate costs for a different reconfiguration that didn't happen. So this is a limitation. There were other system-wide changes across the country and in different areas that happened at the same time, and these might have overlapped with our analysis. And finally, the data, as I mentioned back at the beginning, were difficult and time-consuming to collect. So it's not complete, it's quite complicated, and there are various assumptions made around unit costs and time spent by staff and other things. So in terms of conclusions and implications of using the framework itself, this is the first time this framework has been used to perform an implementation cost analysis for major system change. We've begun to explore components and costs and other aspects involved when a change is being designed, planned and implemented, and we've provided a case study in the London part of the Respect21 study showing how to investigate these costs. It's often assumed that implementation costs can be ignored, but they're not zero. Somebody has to pay for them. So we've started to open the black box of implementation, if you will, to try and allow fuller investigation of what these costs are. Something that we found incredibly useful was being involved from the beginning with our colleagues in terms of the qualitative work. This is very important because otherwise we would have had no access or very limited access to the data that we used, and a lot of the information would have been lost. It's also been really crucial to have input from NHS clinicians and managers throughout the analysis, as well as input from other NHS and external staff. It's likely that including implementation costs in cost effectiveness analysis would make major system change appear less cost effective. So this could potentially influence future decisions regarding major system change, and it could also have an impact on how these changes are supported. These kinds of decisions are not easy to make, and we hope that this framework and the principles that we've set out will make this type of cost analysis more transparent and that more people will consider doing them, so decisions around implementation and major system change can be based on better evidence. Thanks very much for listening. If you have any questions or comments, please add them below, or do please drop me an email if you have any comments. My email address is on the first page of this presentation. Thanks very much.